so I guess the message is that what we're saying, whether it's the biopsychosocial model or person-centered care or whatever the framework is, these things are there to enhance practice rather than make it smaller or narrower. Um, but it does mean that there may be things that if we take on a new approach, we begin to shift, then actually there are interventions or treatments which we no longer do. We say actually, spending 10 minutes palpating someone's L4 is
Yeah,
not congruent
yeah,
with an activist model or a person-centered model.
yeah,
That I can spend that 10 minutes doing, I can spend 2 minutes or
yeah,
whatever. But so in a way, changing the mindset or the theoretical framework of practice should change your clinical behavior, but not necessarily drastically. I.e., you can still touch people. You can still
yeah,
do neck manipulations if you like to do it,
yeah,
right? You can still
yeah,
do those things. So I think sometimes the fear is, well, I can't just talk to patients all
yeah,
day. I like to touch them. You can still touch them, but the touching's a bit different, and it's maybe a little bit less touching, bit more talking, and it's a different approach, but it doesn't need to be completely different.
C'è stato
yeah,
un momento
maybe.
in cui pensavo che questo video non sarebbe mai uscito, invece ce l'ho fatta e sono davvero contento perché ho avuto modo di fare due chiacchiere di qualità e di valore con Oliver Thompson. Per chi non lo conoscesse, è un osteopata e ricercatore che ammiro davvero tanto perché non gliene frega di niente e porta avanti il suo operato, il suo lavoro e sostanzialmente lo fa penso, per migliorarsi come persona, ma anche tanto per migliorare la nostra professione come di osteopati. Quindi tutto quello che fa, per quanto forte, per quanto diretto e a volte incisivo, lo fa sostanzialmente per evolvere la nostra professione. Infatti, insomma, sotto certi punti di vista è stato anche criticato da alcuni osteopati, da alcuni professionisti, perché ha messo in dubbio tante cose e quando si mettono in dubbio degli aspetti legati fortemente all'identità di una persona, è normale che poi dopo gli animi si scaldino. Ecco, perché fa tutto questo? Perché adotta la mente di uno scienziato, una mente curiosa, una mente che costantemente mette in dubbio le proprie idee, i propri comportamenti e il proprio operato. E questo penso che sia una delle qualità, delle caratteristiche più importanti da avere come persone e come professionisti. E te lo dice una persona che proprio non ragionava in questi termini, ma mettersi costantemente in discussione e adottare appunto una mente aperta di uno scienziato è sicuramente un ottimo modo per vedere le cose da una prospettiva diversa ed è un ottimo modo per portare avanti una pratica evidence-based. Ora, prima di vedere il video, ci tengo ancora a sottolineare alcuni aspetti che ha esplorato Oliver nelle sue ricerche. Di fatto si è concentrato su quelli che sono aspetti legati a una pratica incentrata sulla persona, a un approccio BPS, un approccio fisico psicologicamente informato e tutti quelli che sono quei blocchi, quelle credenze, quegli ostacoli che i terapisti hanno all'implementazione di questo tipo di pratica. Ostacoli che nella maggior parte dei casi derivano da aspetti identitari. Quindi il terapista, il professionista, sviluppa poi nel corso della sua formazione un certo tipo di identità ed è normale poi che quando questo tipo di identità che è costruita anche da scelte terapeutiche, da comportamenti, da credenze, viene messa in discussione, ci possa essere un effetto backfire o una situazione di distacco anche da parte della persona, del professionista. Ecco, ricordiamoci il perché Oliver fa tutto questo, per evolvere la nostra pratica, quindi per migliorarci come professionisti. E un ragionamento critico è il modo migliore per farlo, quindi ripeto, lo apprezzo tantissimo. Ora, prima di andare a sentirlo, torno un attimo all'inizio del video, in cui avevo detto che è stato quasi un parto fare questo video, perché? Perché, giusto velocemente, ti racconto com'è andata. Sicuramente ho tante qualità, tante abilità, tante risorse. Ehm, Non sono fortissimo sull'inglese, per carità, lo capisco e mi faccio capire, ma non sono fortissimo e il mio inglese è un po' maccheronico. Quindi ho fatto questa intervista con Oliver, questa chiacchierata. Dal punto di vista dei contenuti top, siamo riusciti a parlarci. E non ti nego che poi dopo, mentre la facevo, mi sono sentito un po', insomma, ecco, un po' così, senza utilizzare termini, perché di fatto non sono molto confident nell'utilizzare l'inglese in modo fluente, soprattutto se devo fare determinate riflessioni, porre certe domande, parlare di determinati argomenti. Per carità, mi viene più facile così che parlare del andare a fare la spesa, però questo perché lo dico? Perché di fatto, insomma, quello che mi piacerebbe è che tu possa concentrarti sul contenuto. Quindi dimentica il mio inglese, farà schifo, te lo dico, farà schifo il mio inglese. Ci sono i sottotitoli in italiano che puoi mettere. Perché lo sottolineo? Perché è stato difficile, perché ho passato tipo ore a provare a doppiarla in italiano, perché volevo risultare perfetto, forse, risultare, no, preciso, preciso, come sempre viene fatto, ma poi a un certo punto ho detto, ma sai che c'è? Chi se ne frega? L'importante è il messaggio che arriva, in un modo o nell'altro il messaggio arriva forte e chiaro, e alla fine della fiera, che dire, dovrò migliorarmi su questo, e quindi è un modo anche per passare anche a te questo messaggio. Quindi il tema qual è? A volte non ci si sente troppo in grado di fare alcune cose, magari ci si sente un po' in difetto, non ci si sente perfetti, e sti cavoli, soprattutto se anteponiamo un determinato obiettivo e dei valori e crediamo tanto in quel qualcosa. Sicuramente se vogliamo migliorarci, se vogliamo evolverci, dobbiamo uscire dalla nostra zona di comfort. E fare queste cose, così come adottare una mente critica, è il primo passo per poterlo fare. Quindi, che dire, goditi questa intervista, concentrati sul contenuto, perché le riflessioni che faremo con Oliver, insomma, ti porteranno a comprendere quanto possiamo migliorarci, quanto possiamo evolvere la nostra pratica. Quindi, buona visione. Thank you so much for this time with me.
Thank you, Matteo.
You do a lot of great stuff for osteopath and also
I'm
other
not
other
sure.
professional.
I think some people would disagree that it's good for osteopathy, but
Uh,
it's good for scholarship and for critical thinking, I think.
yeah, open-minded
Yeah,
thinking, the mind of a scientist.
I try.
But for osteopath, sometimes it's difficult
Yeah.
to accept.
To process.
To process, yeah, yeah. And I would like to talk a little bit of our profession in Italy, and because we are on the brink of professional recognition for osteopathy, but there is still a lot of confusion with the osteopathic community.
Yeah.
And one of the biggest problem instead is maybe the role of somatic dysfunction
Yeah.
we were talking about. What do you think?
I know I've got good friends and colleagues in Italy,
Yeah.
and I very much enjoy going there to examine. It's a nice little holiday in Milan or Florence, so I want to keep people sending me invitations. But intellectually, somatic dysfunction. I understand. Sorry, I understand that it's fantastic news that osteopathy in Italy has been regulated, which is good news.
Yes. Yes.
But it's like is it a double-edged sword that the regulation is contingent or dependent on or based around somatic dysfunction as being a
Yeah.
thing which has implications for the development of illness and pain and health, etc. So I think that's problematic. I think for Italian osteopathy and osteopathy generally, that the evidence that we have around, or at least how somatic dysfunction is traditionally conceptualized as being something that resides within the body, some impairment or some perceivable change in structure or
Yeah.
location or position or however, Pratt and Tart, those acronyms, if you remember those,
Mechanical, only.
mechanical, and that the osteopath can reliably assess and palpate that, and that they can meaningfully influence that. I mean, all these different steps, none of which have been shown to be the case with the evidence that we know. I know that in Italy you've got groups which are broadening or broadening the conception of somatic dysfunction with existing theory, whether it's an activism
Yeah, yeah,
more
yeah,
predictive processing and much more contemporary kind of
yeah.
theory and philosophy and neuroscience, which is good. It doesn't really escape the fact that when you watch osteopaths look for somatic dysfunction clinically, they're still utilizing a very mechanistic
Approach.
approach. And
Yeah.
I just don't so I don't whilst I think it's great that osteopathy and osteopaths in Italy are broadening the theoretical basis by bringing in these ideas. You can't really get around the fact that the claim that there are very specific problems or dysfunctions which lead to big problems in terms of health
Yeah,
and illness,
yeah.
that's just not supported by the evidence.
By
So I think
evidence.
it's a challenge, you know.
Yes, I totally agree with you because there is a big double-sided
Yeah,
of this situation because at the end, osteopath, we have to treat primary pain. We have to do prevention.
that's right.
But
Yeah,
if I have to work with somatic dysfunction, it's difficult to do this because the pain is multifactorial,
yeah,
and it's more related to the person.
yeah. And the challenge, you're right. So as you speak, I'm remembering the linkage between somatic dysfunction and prevention. And there's been some increasing studies, at least in the journal that I'm involved, or one of the journals I'm involved with, iJOM. We've had some papers submitted which have looked at the prevalence, so that's right,
Yeah,
of somatic dysfunction in healthy individuals. And
yeah,
I
yeah,
think that or individuals which are yet to have disease or illness manifest, but they have these secret, quiet dysfunctions. And I think these and if they become significant or clinical, then the patient becomes unwell. And I just think that it's a backward step to how to think
yeah,
about people as being machines that break down, and there's a bubbling under the surface, bubbling
yeah,
problems.
yeah.
And so I think it's really challenging.
Yeah, it's challenging. In fact, sometimes I said to my friend, one time I want to go to an osteopath and said, I have back pain. And I'm sure that probably someone finds a somatic dysfunction, but it's not related to me like person.
Yeah.
Maybe I have the somatic dysfunction, but maybe I'm a healthy subject.
Yeah, I mean, I
It's,
think I would even I think I'd go further in the criticism, deeper in so much as even the notion, the idea of a somatic dysfunction, i.e., a particular area, let's say in the spine, but it could be anywhere, right? Shoulder, elbow, but
yeah,
let's say in the spine, which has physical characteristics which then lead which can be detected or assessed or reliably determined. That's a
yeah,
problem in itself because the evidence says it can't. Moreover, these things lead to bigger problems or bigger diseases. And again, we haven't got evidence for that. So even the concept of some underlying structural gremlin
yeah, yeah,
creature
yeah,
existing,
yeah,
which no one can really see, but is there. I mean, that's a epistemologically very challenging position. So I don't even the case. So I think when you said, and maybe you were being casual and a joke that you might have somatic
yeah,
dysfunctions. If everyone has somatic dysfunctions, then clearly that's just what it's like to be a normal human being to have these differences. So I think it's kind of medical, it's pathologizing or dysfunctionalizing. If that's a word.
yeah, 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 yeah.
Things which are normal.
Hypermedicalizing. Yeah,
It's like that. Yeah,
hypermedicalizing.
it's like the structural stuff in the spine from Prinjicci. Everyone has disc tears and under
Yeah,
MRI. Everyone has these things. So these are normal variants.
yeah, yeah. And the problem is also that if you go to the to Instagram or TikTok,
Yeah.
you see a lot of video, a lot of message that are communicated to people. And the
Mm,
problem is that people go to the health professional with a lot of cognition about
mm,
the process of a resolution of the pain. Like, is
yeah.
I have a dysfunction, you have to fix it.
Yeah.
But the problem is that this idea came from professionals.
Yeah, for sure.
So it's
Yeah.
normal that the patient think this kind of stuff because everyone say that one,
Yeah,
say
exactly.
this
And
one.
and these beliefs that, you probably know Bendalo's work, how practitioners or patients develop these beliefs about back pain or shoulder pain, that it's from a variety of sources.
Yeah,
Practitioners, social media, it's handed down generationally from grandparents and all those sorts of things, or even experiencing a loved one that has back pain or pain. We create or develop these beliefs ourselves, but the worst thing that a clinician can do or an osteopath is to reaffirm
yeah,
and cement these unhelpful beliefs or
yeah,
even emphasize them even more. So I think it's as you know, it's the discourse which I think the challenge with somatic dysfunction is both itself as a what's the word, a kind of fallacy, but also the language around it, right? So it's a double
yeah.
edged, it's doubly bad. It's both bullshit.
Words matter. Words matter. How
Words
do you
matter,
do you you
but
know you know?
yeah, it's both it's doubly wrong. So it's both untrue as a clinical entity, but also even speaking about it as a profession and talking about it amongst ourselves and with patients carries with it unhelpful side effects or consequences. So I just think it's
Yeah,
an unhelpful concept.
yeah,
So good luck
yeah.
with that.
Yeah, yeah. The consequence is also that if the treatment don't doesn't
Yeah,
fix the dysfunction, the idea, the belief of people grow up.
yeah,
No?
yeah,
So it's more difficult to change
for
the
sure.
mind of the patient.
For sure, and it's hard. I have patients come in and they want simple fixes, or they say, "This is can you find the area or the one causal aspect
Yeah,
of my problem?" And you're faced. It can challenge their relationship because you obviously want to validate their concerns and say, "I
yeah,
hear you. I appreciate this is your thinking and these are your thoughts." And however, this is kind of where I am, and you've got to somehow find a middle ground. Wouldn't it be fantastic if patients came into your clinical practice and they were already recognizing the complexity and uncertainty and biopsychosociality of their illness or their health, but they don't. They often come, there's often a mismatch, right? And you have to
yeah, yeah.
negotiate that.
You have to deal with the mismatch. It's not easy because
Yeah.
you risk a big backfire effect sometimes.
Exactly. Well,
It is
you
risky.
rupture the relationship. They say
Yeah,
this guy Matteo can't find the somatic functions in my sacrum. The osteopath down the road, they did, and so and I think they were able. If we don't meet patients' expectations, that there is a coming together where patients might expect or prefer a certain way of care or treatment. We have our own approach based on maybe the evidence, and
yeah.
sometimes they clash, or often
Yeah,
they clash.
yeah, conflict starts
Yeah.
to grow up, and in this stuff, I think that is important the communication of
Mm.
the osteo or the physio in the first question in the clinical encounter. Because if I say to you, Oliver, talk me about your pain. Talk me about what you feel on your
Mhm.
elbow. I'm just talking only about bio
Yeah.
and not
Yeah.
including by PS.
Yeah.
So,
Exactly. Yeah.
like an open question, like tell me your story, talk me
Yeah.
about what you want. Is a way to expand the
Yeah.
view of the patient.
Yeah, quite. And in the UK and I think in Italy too, and anywhere where osteopathy tends to be within private healthcare rather than public
Yeah,
healthcare, which is almost everywhere, right?
yeah,
We're lucky to have typically lots of time. So we have maybe 1 hour or 45
yeah,
minutes, maybe half an hour. And so we have lots of opportunity to explore these things through conversation, through language. That doesn't mean to say we can't use touch. And actually, one might argue that using touch and the osteopathic
mm,
touch, palpation, whatever
touch.
you want to call
Yeah,
it, is one part of that story. And
yeah,
it's perfectly helpful to push on someone's area of their body which they find important and meaningful to them, for example, the
Yeah.
lower back, and to then have a conversation about that experience and to try and derive or try and create some knowledge about how they're conceptualizing it, what their beliefs are, what it means to them. So I think in that way, touch and palpation and manual therapy, all that kind of stuff, can be used in a much more meaningful and useful way.
Meaningful way. Yeah, it's
Yeah,
like a way to validate, to test, to recognize the structure that is feeling the pain for the patient, to guide the patient,
for sure.
to to give confidence, to give a trust,
Yeah, trust. I mean,
so,
you know, you probably have it yourself when patients come and they say, and they maybe they've seen, and I'm not criticizing doctors or GPs, they do some great work. They don't have the time to maybe look at patients with sciatica or back pain or neck pain or radicular arm pain. They just, you know, they may just whatever they do. But when you see patients that have been to clinicians that haven't taken the time just to look at them or to touch the area, that's
yeah.
extremely. And when I say touch in a sensitive, caring,
Yeah,
deliberate way.
like mom that touch you when you get
I
home.
think so. I think so. I think it's a bit, I'm not sure. I think it's a bit different, only in terms of the perceived expertise. So when you're with a patient, if you just gave them a hug,
Yeah,
like mum, it's a bit different, or I think it would be perceived as being different by the patient when you deliberately feel and, oh, is it sore there? And oh yeah, I
oh,
can.
okay, okay, yeah,
And
yeah,
so
yeah,
I think I don't I think on the I think the patient perceives some expertise there, some skills, even if the skills are bullshit, right?
yeah,
But
yeah, yeah,
there's a perception of expertise which then creates trust and confidence, and also the patient thinks, oh wow, this Matteo is really taking his time to try and understand what's
yeah,
going on.
yeah.
He's really feeling the area. He's checking everything, and so I think that has some carryover in terms of outcome. Whereas if you just hug patients
Yeah, yeah, it's different.
or just
Yeah, no,
stroke
no,
them,
yeah.
not only
No,
would it
no.
be a bit weird.
Yeah, 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 yeah. It's more useful to find
Yeah,
what is in this area, and is an opportunity also to say to the patient, this is your pain. I feel your pain. This is your
yeah,
pain.
yeah,
This is your
yeah,
pain. When you stay more tense, is more. When you relax, is less. What do you think about
completely.
if it was the herniation? Why when you get relaxed is better?
Completely. And you can do the same thing, the same touching thing, right? And there are two realities here. You can either, reality one is what you just said when you say to them, so, yeah, or I can see that this is sore. You know, you push and they say, ow. And you can say, you can have a conversation about the experience is
Yeah,
the one option. The more traditional osteopathic option is, oh yes, I can feel the restrictions, and you start talking anatomy and dysfunction, and you, oh yes, your shoulder and your hip, and it's a completely different conversation, but the behavior, the action is exactly the same. So I remember, I think it was on the end of a Peter Sullivan YouTube kind of lecture or something, that he said, maybe it was a paper, I can't remember, but he said,
maybe.
maybe he said, what did he say? It was really good. He said, even if you think it, don't say it. So even if
Yeah,
you
yeah.
just don't
You have
just don't say
to.
it. So the best thing osteopaths can do is just say less.
Yeah,
They-
yeah,
Even if they do exactly the same, they still do the biomechanical mechanical treatment. Just say
yeah.
less.
The
That's an
correcting
improvement.
reflex. The correcting reflex. You have to close your mouth
That's a good
and
start.
maybe ask
Yeah.
instead
Yeah.
of saying,
Yeah.
"Oh,
Yeah.
what do
Yeah.
you think? What are you feeling? What are
Yeah.
your emotions? What is happening here?
Yeah.
Or you are the captain of you are
Exactly. Yeah.
the driving guy of your body and your feeling and your experience. So it's like a way to go out from practitioner
Yeah.
approach, no?
Centeredness, yeah.
Therapist-centered, therapist-centered instead of patient-centered. You are the patient.
Exactly. Yeah, and I think there's probably maybe two or three reasons why osteopaths feel the need to have a strong anatomical discourse with patients. I think number one is that I think they genuinely think it's helpful for the patient. I think they think
Yeah,
actually, when I'm telling the patient that it's their left facet joint L2 that's the problem, I think osteopaths think that's good information to help the patient understand their problem.
yeah,
What they don't realize is that the evidence says that strong pathoanatomical discussions and descriptions in some patients can be unhelpful because it builds a schema or a schemata, which is mechanical and biomechanical and biomedical. So I think there's that. I think osteopaths genuinely think it's helpful. I think the second thing is there's something about the demonstration of knowledge. Look how much
mm,
I know, and I'm an
yeah.
osteopath, and osteopaths know lots of anatomy, and
Yeah, I'm the professionist. I have to say things to you. I don't have the permission to stay in silence.
yeah,
I have
exactly.
to say something
Yeah,
because if
yeah,
I don't say something, it's a
yeah,
problem.
yeah,
But they don't know that the silence is a very, very powerful
yeah,
instrument used in the clinical encounter also.
yeah. So yeah, I think talk less,
And do more.
do more, or even do the same. I mean, I've got a good colleague, Jerry Draper Rodi, and he makes a good case that osteopaths don't even need to necessarily change the treatment, just not say as much and just I think it's the kind of it's the what's the it's draping the interaction in a very strong biomedical way, which for not all patients, but for some patients can be really quite unhelpful. So even just do the same, but just say less.
Say less. Yes, yes. And I suggest to you one thing that I'm thinking in those time, and is this changing the somatic dysfunction in the drivers of the pain of the person. The same concept, but translated to I have to find what drivers
Yeah,
is working more in the pain experience of the
yeah,
patient. I have to understand the person in front of me. This is the
yeah.
somatic dysfunction that I think now is important. Do you
Exactly.
know what I'm
Yeah,
saying?
so I think you're right. I think, and maybe this is where it's going, is that in Italy at least, that the recognition that somatic dysfunction in its classical form is a very narrow reductionist phenomenon. And so now the conversation is, well, the whole person's a somatic dysfunction. Is that the best way to talk about people? Probably not. But maybe it opens up the definition or the concept of somatic dysfunction. Um, my own preference is that I wish that whoever came up with the idea would just go. I think it's not a helpful. I don't think it gives any. I don't think it affords any kind of clinical benefit, kind of
Yeah,
benefit or utility. I don't think in education it's helpful. I don't think in professional practice. I just don't think it's helpful. I think we could lose it, and
yeah,
actually, it wouldn't tie our hands to this particular way of practicing, which is to pursue the discovery of
yeah, yeah.
lesions, osteopathic lesions,
Sort of lesion. Yeah,
whatever.
yeah.
Yeah, dysfunctions. I just think it's a stupid idea.
Yeah, it's limiting. you, you go soft. But I agree. I totally agree with you. And this,
Yeah, sorry, just to break it down even more, the term is so somatic in itself. It just appeals
no
to kind of
sense.
the
Yeah,
body
yeah,
and dualism. Dysfunction means it's just it's just kind of abnormal. It's
yeah,
just a crappy term. It's both a crappy term, um, semiotically, if that's the right phrase, but also conceptually is crap because it leads people to think that they have to just find these things.
yeah, yeah. And
And
fix it,
that's it.
no?
Yeah.
And there is also a mismatch with the osteopathic principle, body, mind, and spirit, but at the end is only somatic dysfunction. And you develop
Yeah.
a way to work and an identity about
Yeah.
your profession. And I think that the biggest problem now for osteopath in Italy is their
Mm.
identity and their label.
Yeah.
I'm an osteopath and do this stuff.
Yeah.
And we forget we forgot the person in front
Yeah.
of us.
And it's incredibly hard. I think that same identity crisis is an issue across the globe, really. You know, you look at the osteopathy in America and the US, it's shrinking. It's a very small, um, or rather, even though there are qualified DOs, osteopathic physicians, it's an increasingly smaller number are using manual therapy or practicing in what we would probably think as
Yeah,
being an osteopathy or an osteopathic approach. So in the US, there are issues. In the UK, it's this conversation has been going on for a long time. It's a bit different here because osteopathy in the UK is allied health, so it's kind of in the same ballpark as
yeah,
physiotherapy and others. But I think I don't have an answer about how to create an identity which seems to be different or justify the existence of a different profession.
yeah.
I don't have a good answer, and it doesn't mean to say there isn't a good answer. I just haven't come up with an answer. You know?
It's an idea. I hope that in the future will be an hybrid figure that is a professional, health professional,
Yeah,
finish,
very
not
hard. Yeah,
osteo, not physio. Yes, if you have to make a rehabilitation with the LCA rupture, is for physio
yeah,
for sure. But if we work with the prevention or chronic pain, chronic primary pain is for osteo, for physio,
yeah. It's
for health professional.
it's incredibly challenging, and we the word is it's an intractable problem. It's a problem that we haven't been able to solve in osteopathy for the last 30, 40 years. No one's really figured it out, and no one seems to be getting close to figure it out. I mean, I don't know because the premise is just in the landscape of evidence-based practice and person-centered care and the biopsychosocial model and activism, whatever kind of theoretical framework you think
Yeah,
about, all of them are professionally agnostic, meaning that they kind of level the playing field. That if you're adopting an evidence-based approach, and you're adopting a biopsychosocial person-centered approach, then it begins to remove the variation in practice that you can't be doing weird stuff
yeah,
to the skull because it's both poorly evidenced and not person-centered. So it begins to influence our professions, and so unsurprisingly, there's a less of an argument to keep these distinct professional disciplines when they all
labeled.
kind of look the same, right? So it's really difficult.
Yeah, it's a social problem, maybe.
Which I can see why in Italy I can kind of understand, that in order to get professional regulation to put a flag in the sand, in the moon, in the sand to say we are
Yeah,
a profession, you've got to say something why you're not physiotherapists. You've got to you've got to say have some reason, and I guess
yeah,
somatic
yeah.
function works.
Yeah. In my in my own experience, I say the rehabilitation is not my own. Other stuff is my own.
Yeah,
This is the difference because we believe in only one figure that is good to work
yeah,
is that work well, no?
yeah,
In an evidence based approach. And one problem also for osteopath is understand the limit of our intervention because some osteo said to us, but I'm not a psychologist or
Yeah.
I'm not a movement scientist, but what the thing that I say is, if you have to explore the life, the experience of people, you haven't to do
Yeah.
to be a psychologist for one side, and from one the other side is if I have to guide the patient to move her body in a different way, to go up and down from a chair, to walk, to grab something in his house, and you don't have
Yeah.
to be a movement scientist, no? But the important thing is the message
Yeah.
that you pass, trust, confidence, value based activity,
Yeah.
of this kind work, this kind of stuff.
Exactly. Exactly. And I remember, again, I forget the paper, but Mary O'Keefe wrote about this that said something like, you know, most of the kind of in terms of psychosocial aspects of pain or the stuff that osteopaths would come up against or interact with are things like cognitions, beliefs, behaviors. They're not necessarily true psychopathology in a small proportion of patients, maybe, but then you would know to refer. They're not
Yeah,
true phobias in the sense of whatever the ICD classification is for phobia. These are kind of movement anxiety
yeah,
um, events or issues. So I think you're right. The claim that I'm not a psychologist is a poor one. The next thing is that if on the one hand you're going to claim to be holistic and person-centered, you can't on the other hand say, well, I'm not really interested in psychology. It's not really my thing. It's a contradiction. Either you're interested in the person or you're not interested in the person, and you want to be a vet or an engineer or I don't know, you want to build houses.
yeah.
But
Other stuff.
the minute you make the claim, the minute you say, well, I'm interested in people who are suffering, then that's kind of it. I mean, you should be open to any theory or approach that within your scope. And so you're right. If there are clear, mental health issues and challenges or deep kind of societal or social problems, of course you should refer on.
Yeah,
For most of our patients, these are patients that just need some psychological support or social support or some education or some conversation around the psychological aspect of their lives that doesn't require a PhD in psychiatry, does it? It just
no,
requires some
no.
listening and some conversation, as you know, some conversation techniques and some strategies.
Yeah, yeah, for sure. Is also this is the part of the mind, the part of the body
Yeah.
is also for movement scientist or
Yeah.
athletic performance. Is not this
Yeah.
kind of stuff, and you have to deal with those kind of stuff because at the end, pain is half sensorial sensorial part and
Yeah.
half emotional part. So
Yeah.
in the middle, there is the person.
Yeah. Yeah. And it doesn't have to be, and I think it's changing, but it doesn't have to be one or the other. I mean, sometimes a psychological approach just contradicts a kind of more some of the manual therapy approaches. But for most osteopaths, as we were saying, either just don't say anything, but just by asking some questions, what are you expecting from today? Or what do you think is causing your pain? Or have you got any
Yeah,
thoughts about what might help you? These are questions which are so easy to say, so easy to ask, and they invite some really, interesting responses and invite the patient to really express their own views and values. And it doesn't take much. I mean, you can still do whatever you want to do to the body, but just ask patients those questions, and it begins to really put them at the center. So, what do you think would help
yeah,
you today? And they might say, I don't know, you're the expert.
yeah,
But then you've got to be ready for that, and you might say, "No, I understand that, but I'm really interested to know what maybe it's helped you in the past, or what sorts of treatments have been useful for you." And they may start to think, "Oh, okay," but what it tells them is that okay, this person, this osteopath, is really interested in what I think and what I
yeah,
have to say, and that in itself
yeah.
is empowering and develops that relationship.
Yeah, he's eliciting the autonomy, the competence,
it moves the power. It moves the power to them.
Yeah,
They choose. And some patients may not be ready. They may say, I don't know, I don't,
yeah,
it's and that's fine too. And you've got to be sensitive to that. But it's such an easy thing to ask, Pete. I mean, it's like 6 words. What
yeah.
do you think?
Yeah,
It's not
yeah.
difficult, is it? I
It's a
mean,
curiosity, no? Right? Curiosity,
exactly.
but the problem here, I think, that is related to the identity because the osteopath have an identity of a fixer. So if I am a fixer, I don't have to ask you
Yeah.
because
No.
I'm the
Yeah.
expert.
Yeah,
I
for
treat
sure.
you. So
For
I don't
sure.
care about that.
For sure.
Why I have to ask you something? You have pain here. I have to fix it. No, so
But it tells you so much. And thinking about my practice, those sorts of questions have really changed how I approach patients. And because if patients say, I want to be fixed, for example, you ask the question, how would you what kind of things do you think will help or what do you think would help you today? And they say, I want you to find my pain and fix it. Already that tells you about their own
something about
framing.
patient. Yeah,
Perfect. And you can then say, okay, that's great. And what do you mean by that? And so it doesn't mean to say you don't give them the fixing. Maybe you give them the fixing, but at the same time, in the longer term, you're thinking about
yeah,
how is this person making sense of their problem? And you can introduce some conversation whilst you're fixing them
yeah, yeah,
without saying anything.
yeah, yeah.
And so that's the negotiation. It's give or take. It's okay, you want this? We can do this, but at the same time, we can explore this.
Yeah, yeah, it's a way to reduce the conflict and say, okay, you have to this idea, this belief. We start with this
Yeah.
maybe, and later we can have a discussion
Yeah.
about why do you think
Yeah.
this kind of stuff. What is your idea? What are your ideas?
Yeah.
This stuff, and
Exactly. There's a good evidence or ethical and evidential argument there to if fixing means to do some manual therapy, we know that manual therapy has a kind of transient hypoalgesic effect. It can feel good.
yeah,
There's nothing wrong with manual therapy. I'm not anti-manual therapy, but as we said in our paper, to rely on a single intervention, so mono interventionism, just manual therapy as being the main thing, and psychology and talking and activity advice is all kind of someone else's problem. I think
yeah.
that's a real limitation of the profession or potential.
Yeah, yeah. It's very, very, very difficult to change the mind
Mm.
for osteo. But every time I say, if you want to change the mind of the patient, you have to change your
Yeah,
mind,
yeah,
your approach.
yeah.
And I find a lot of time, a lot of not psychological flexibility in therapists before of patients. And because we are people and the same kind of stuff are for therapists and for people. So
Yeah.
we have to elicitate maybe the psychological flexibility of therapists before patient.
Exactly. And just being humble and I'm constantly I guess it's being in research, you're a skeptic by nature, and you're constantly critical of knowledge. You're critical of yourself, and so I'm constantly thinking, could I have done that better, or do I really understand what's going on here? Listen, I often make mistakes. I have patients that aren't happy. I get it wrong as much as
Uh,
anyone. Um, but I think at least I'm open to being wrong, and I'm always wondering, could I have done that better, or did I say that right, or did that interaction go as I wanted it, or how was that interaction perceived by the person? Um, and I think that's just being self-critical and self-reflecting
yeah.
and acknowledging that actually, no one really knows what they're doing. Everyone's kind of making it up, and you want and reckon that there aren't obvious answers much of the time. There aren't black or white answers. That there isn't. The clinical practice is just uncertainty,
Yeah, totally
landscape of
uncertainty.
uncertainty.
Well, the beautiful thing when you feel comfortable to stay in uncertainty because
Exactly.
every day is uncertainty. You
Yeah.
can't control
Yeah.
this kind of stuff. And I like your argumentation of before. It reminds me the book. I don't know if you know it. How Minds Change of McRaney that
Yeah, I've heard of
talks
it.
about to use the mind of a scientist that every time ask to yourself why this kind of work
Yeah,
works or not, open-minded.
yeah. And it can be really uncomfortable as a clinician to constantly, question yourself. Is that right? Is this right? Evidence comes out that says this is effective, this isn't effective, this is reliable, this isn't reliable. It can be really challenging, but I mean that's it. That's why we do healthcare. If it was simple, we would do something else. Um, so I think that the models and frameworks like somatic dysfunction and similar, they look to remove that uncertainty. That they try to remove the
Yeah,
noise. Try and remove
yeah,
the noise, and you just focus on, okay, the no, no,
the
no,
minimum.
yeah, yeah, there, okay, yeah, and it artificially removes the uncertainty
Yeah.
and closes doors on other areas of the person which are probably more important, in terms of risk factors for pain or the lack of recovery from pain, that sorts of things.
Yeah. It's interesting this this kind of stuff at the end because we have to change. And another big problem that is correlated to these things maybe is the loneliness or of
Mm.
therapists. We say a lot of professional loneliness in Italy because everyone are at the top. I'm better than you.
Mhm.
My ego is
Mhm.
very very strong, and I stay isolated in my
Yeah,
own practice. And
yeah,
so this work of questioning your clinical practice is more difficult.
yeah.
And if you have we are working to grow up a community, a
Mm.
peer community, when you can talk and explore with other
Yeah,
people on the same level, and this is maybe very useful to feel less uncertainty
yeah.
in the uncertainty.
Completely. And I think one of the things that I do as a kind of side job is to similar to you do is to mentor clinicians, whether they're experienced or less experienced, but just to offer a safe space to
Yeah,
talk and to say, I don't understand this or I got this wrong. I mean, even as I express, and I'm more than happy to disclose all of my clinical failures. I don't, I'm not embarrassed. And I think all of us should just be confident to kind of in our errors that we're not machines and we get things wrong and we're open to learning from them. And there isn't probably enough of a space or not enough spaces for osteopaths to have these conversations and to question practice. I mean, I know what it's like. If I question things in my profession, I get a bunch of hate mail or hate posts, and I've
yeah,
got kind of groups in various countries, probably in Italy too, which aren't my biggest fans. But it's perfectly good and right and part of maturity to be able to criticize or think critically about stuff which we do. I mean,
yeah,
that's what it is to be a profession, and the same with individual clinicians being able to say, that somatic dysfunction thing, it doesn't make sense to me. I don't think it's a good idea. I think there are other ways to go about helping people. That shouldn't be blasphemy. You should be able to say that, and people should be open to having that discussion. But yeah.
yeah, yeah. It's a fact. We are trying to do this, and it's beautiful for me because you learn a lot seeing other therapists working.
Mm.
Because we recorded the visit, so you learn a lot
Yeah.
of strength and quality and
Yeah.
characteristic of other professionals.
Yeah.
So is the same empowerment that we would like to make with patients.
Yeah.
We make the same process with other therapists. So you
Yeah.
you are doing well. This
Yeah.
kind of stuff, beautiful thing. I
Yeah.
want to grab this thing and
Yeah.
using in my own practice.
Yeah.
So it's a safe moment, a safe
Yeah.
place to grow up.
And I work. academically and clinically with physiotherapists, with chiropractors, with podiatrists, lots of different health professionals within the same kind of space, musculoskeletal care. And there are approaches and characteristics which I think are fantastic. And I think the idea that osteopathy does something particularly well, or any profession has a, I'm unique because we're best at this, or we're best at that.
Yeah,
I think, and goes back to your idea of integrating the professions or merging all the different professions. I think there's an argument to say that we have so much more in common than we have different, and so much shared values, shared skills, shared knowledge, shared
yeah,
scope. It makes it hard to justify, well, apart from some different histories, but even the histories overlap.
yeah,
I think where
yeah.
chiropractic came from and physiotherapy, is there a good reason to have the three professions? But
Yeah, maybe the most important fact is to to reach the the relationship with people. No,
yeah,
in every profession, the most important thing is the relationship, the therapeutic alliance. No,
yeah,
so we can talk about this with other professionals, with the
mm,
psychologist, personal trainer, nutri,
mm,
and other kind of stuff.
yeah, yeah. And I think probably if you look across, like you said, there are a core set of skills or approaches, like you said, therapeutic relationship, expertise. These things kind of, what's the word? They transcend osteopathy and go across good healthcare, what it is to be a good doctor or a good occupational therapist,
Yeah,
good
yeah,
nurse, they're all the same.
yeah,
And so, yeah, but I also get, like, coming back to the issue again, that makes it difficult to justify regulation in Malta or whatever country it might
yeah,
be,
yeah,
or
yeah,
Canada,
yeah.
or I don't know where else, Denmark, other countries which are still trying to make a case to be regulated when it's not clear what you're regulating, or what's the
Yeah.
particular special ingredient that's being regulated. It's
Yeah,
hard.
yeah. It's difficult. And the last thing I would like to ask you is,
Sure.
what do you think? What What message do you think is better, maybe, to how do you say, to make easier this process of osteopath to change their mind. Cioè, what is your advice to reach more osteopath,
Wow.
avoiding the backfire effect?
Yeah.
Maybe this kind of talk with you, maybe
Yeah.
maybe not so much for the English, but I will do some subtitle and translation. Yeah.
I mean, I think it's really, really hard. Let me think. I think the first question is to think, what is the resistance? Why do some osteopaths not want to change?
Mm.
Yeah. And there'll be a range of reasons why osteopaths don't want to change, or at least move their practice towards a more biopsychosocial, person-centered. And I suppose I'm not going to go through them all because they range from a lack of skills, but also I think just a perceived threat or fear that actually changing their approach will diminish
Diminish. Yeah.
diminish their professional standing. And I think so I guess the message is that what we're saying, whether it's the biopsychosocial model or person-centered care or whatever the framework is, these things are there to enhance practice rather than make it smaller or narrower. Um, but it does mean that there may be things that if we take on a new approach, we begin to shift, then actually there are interventions or treatments which we no longer do. We say, actually, spending 10 minutes palpating someone's L4 is
Yeah.
not congruent
Yeah.
with an activist model or a person-centered model.
Yeah.
That I can spend that 10 minutes doing, I can spend 2 minutes or
Yeah.
whatever. But so in a way, changing the mindset or the theoretical framework of practice should change your clinical behavior, but not necessarily drastically. I.e., you can still touch people, you can still
Yeah,
do neck manipulations if you like to do it,
yeah,
right? You can still
yeah,
do those things. So I think sometimes the fear is, well, I can't just talk to patients all
yeah,
day. I like to touch them. You can still touch them, but the touching is a bit different, and it's maybe a little bit less touching, bit more talking, and it's a different approach. But it doesn't need to be completely different.
yeah. Maybe it's the fear to lose what you learn in your 5 months
Yeah.
of study. Yeah,
Yeah, exactly. So I think it's that. And
the
I
fear of
think,
less a part of your identity. Maybe.
yeah, yeah. And people become very invested. They spend money and they spend
Yeah,
time learning osteopathy, but you can still do a form of osteopathy, but it's just different to what you were taught.
yeah, yeah, yeah. And thanks so much, Oliver.
No worries, Matteo.
I think that we had talked about a lot of interesting things, maybe.
Yeah, very much. Yeah. Yeah, I hope your audience can understand my quick English.
But not mine for sure. But the next time maybe it should be better. Okay.
No, it
And
was good. It was good.
now we can cut some part, but I appreciate a lot your time with me, and we need much more of this kind of stuff in Italy, everywhere, and
Yeah, happy to do it again. I'm happy to put you in touch with colleagues of mine that
yeah,
which have
yeah, for sure.
even more.
Like Milan, if you
Yeah.
or other because one other problem I think is that if you go in the field of physiotherapist, you are a physio and you are not you don't know very well IPS,
Mm.
psychological informed practice, but you know that Peter O'Sullivan is a must. You know that
Yeah.
other physio are the best in the world. For osteopath, there are a lot of guru.
Yeah.
No, guru. Not so. Some people like
Yeah.
us, maybe, not famous, not very, very, very famous.
Well, I think I mean I think
You are
you're right.
famous a little bit.
No, not really. I think you're right in so much as there are lots of gurus, and I think an argument which has come back at me and colleagues of mine who are in research and academia to say that all we are now is research gurus. So, and I think that's a fair comment that what I say should be criticized as much as anyone else's. So, as with my publications, that I'm more than happy to be critiqued and criticized and I don't care. I mean, you're not criticizing me, it's my thinking, my work. So
Yeah,
I'm able to separate my work from me. I don't take things personally.
yeah,
It does bother me when people misrepresent my views or my papers or those sorts of
yeah, I
things.
know.
But I think that we should all be open to criticism. It's not that's a like I said, that's a robust profession, a good mature profession. Obviously, the tone of that criticism needs to be appropriate. So not personal attacks or not stupid videos on social media or Facebook, making
But
personal attacks about in the individual, these ad hominems, but actually more about the research or the work.
research and the idea, but
Yeah,
the most of the time is personal criticism. Not the
yeah,
people
exactly.
feel personal
Yeah.
criticism, and
Yeah, and I think if you work, sorry, you need probably want to go, but if we all operate on the assumption that none of us are, we're all trying to enhance practice or
yeah,
enhance osteopathy,
yeah,
and no one's trying to necessarily destroy it or but we're all trying to do our best.
yeah,
And
yeah,
if that's a work, that's a much more charitable
yeah,
starting point rather than that Oliver, he wants to destroy osteopathy and he hates osteopathy. And then and likewise, I'll go to that person, they just want to preserve osteopathy and they hate
yeah.
research. I think we all need to be kinder, I suppose,
Yeah,
in our conversations.
yeah, because we have to be kind with patients also.
Yeah.
So if you are not kind with other people outside of your world, how you can do the same thing with
Yeah.
patients? Oh, we are human in the
Yeah, I
end.
mean, with me just saying that, I just thought of the What's Wrong with Osteopathy paper, which maybe wasn't wasn't the
Wow.
kindest
You
paper. But
you
anyway,
you 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 had a shitstorm, no?
a
Yeah.
shitstorm. So
Yeah.
maybe if I was going to write that paper again, maybe I would write it in a kinder way.
Okay.
Maybe I wouldn't, but I accept that it perhaps wasn't as kind as it could be, but it wasn't the time to be
Kind. Yeah.
sugarcoat things.
Yeah. Sometimes you have to be
Maybe,
more strong and not kind.
maybe,
Sometimes, maybe, but it's the life.
yeah.
Yeah. You know. So Oliver, thanks so much.
No worries. Thanks,
I
Matteo. Really
hope to
nice.
see if you came in Italy. I appreciate if we can meet together.
Yeah, lovely. Where are you based? Whereabouts are you based?
Milan.
Okay, lovely. Yeah, yeah. I was
Milan.
in Florence. I was in Florence for a wedding in the summer. Oh,
Ah, wow.
Tuscany. Oh, beautiful. I loved
Beautiful,
it.
huh?
Oh my God, it's
Beautiful Tuscany.
heaven.
Yeah, yeah. So thank you so much,
Cheers,
Oliver.
Matteo. Nice to speak.
When I finish the editing, I say to you and I put public on YouTube.
Yeah,
Okay.
brilliant. If you share it on Instagram and just if you tag
Yeah.
me and just
Yeah.
share it and I'll
Thank
I'll,
you.
I'll reshare it.
Perfect. Thank you
Nice
for
one.
sharing this kind of stuff. Have a
Pleasure. No worries. Nice to speak. Bye bye.
Bye bye.